Hi guys, welcome back. This is Dr. Deepak Marwah again, and today I shall be discussing with you regarding the FMG 2019 June paper. I would like you to invest about 1+ hour listening to this, so please put on your headphones and listen to all the core information that I give you. My primary focus would be to make life easier for you because this is the part of the year when the pressure tends to build up, and my objective is to rather simplify things for you. So let's start with the very first question. Every year there's a question on Glasgow Coma scale, so I definitely want you to practice Glasgow Coma scale from the main lecture, and I'm gonna do it here also. The question began by saying calculate the GCS of a patient exhibiting eye opening on pain. Now, when you study regarding eye opening on pain, the information to be remembered is that if a patient is having spontaneous eye opening, you give 4 marks. If the patient opens his eyes on command, that would be 3 marks. But here the patient is opening his eyes to pain, so that would be 2 marks for you. Then he says the patient is conscious but is confused and is not able to tell time. So the basic point is that the patient is disoriented. If a patient is conscious, how would you know that the patient is conscious? The patient should be oriented in either time or in space or in person. What I mean is that if you read about information where a patient is saying like, a hospital is a terrible place to me, I don't want to be here, and just discharge me, I've been here since morning, so he knows what the time is, he knows where he is, he's recognizing that you are a doctor, then it is obviously a score of 5 marks to the patient. But because the patient is disoriented, I'm going to give him 4 marks. The next thing he says, the patient exhibits flexion on a painful, noxious stimulus to the arm. So you can see here, like if I am gonna give a painful stimulus in this particular arm of the patient, then the patient would try to move the arm away. That would again be a score of 4 because flexion, normal flexion, because you're giving pain stimulus, it's gonna hurt, no? So he's gonna move his arm away. So that would be again a score of 4. So if we add up the data, that would be 4 plus 4 plus 2. That would be working out to a score of total of 10. Questions on Glasgow Coma Scale, guys, are very straightforward, but I have seen very brilliant chaps missing it out or messing it up in the final exam. So I would definitely like you to practice this, and let's do a quick practice about how to get this question right under approximately a duration of 1 minute. The first and the foremost thing that you need to check for is whether a patient is having a spontaneous eye opening. And if he's doing a spontaneous eye opening, that's obviously 4 mark. But if he's gonna respond to speech, like you gonna give a command, please open your eyes, and it's a opening of the eyes of the patient, that would be 3 marks. But if you're gonna give a pain stimulus, now how would you give a pain stimulus? One method of delivering pain stimulus is that you can use your thumb, like in this particular image, and press on the supraorbital margin of the patient. Another way is you can use your knuckles and rub on the sternum. That would look a little, I would say, not very comfortable to the relatives of the patient. So what we do nowadays is that we can press on the lunula of the nail. You can press on the lunula of the nail, or you can use your thumb and press on the supraorbital margin, either of the two. And if the patient opens his eyes in response to that, that would be 2 marks, and obviously nil response is 1. When it comes to the verbal response in the patient, if the patient is conscious, how would you know conscious and oriented? You have to check for the conscious and orientation in time, space, and person. Like you would tell the patient what time of the day it is, or where are you, at home or in hospital, or you would ask the patient his personal detail. So if a person is blurting out all the information by himself, then there is obviously no problem. But if there is disorientation, what I mean by disorientation is abnormality in any one of the three. Like a patient is not able to tell you regarding what time of the day it is, where he is per se, he's not able to tell you. Like you pointed to the nurse, and you said, okay, who's she, and he's confused, he's not able to recognize a healthcare worker, he says that's my wife. Now a person is taking a healthcare worker to be his wife, so that's definitely a disorientation. So disorientation in any one of these three would be taken as 4 marks. You would tell to the patient, where are you, because the patient was brought by the PCR van, he's alone, he's unaccompanied, so you thought that, okay, let me get a mobile phone number of this guy. And you said, sir, can you tell me a cell phone number? And instead of telling you his cell phone number, what he's doing is that he's giving you the choices to the abuses. So it is not that I'm giving him 3 marks because he is abusing. I'm just saying inappropriate words to explain to you the fact that the question and the answer are not matching. You simply ask, sir, what is your mobile phone number? And the guy is giving you abuse. That's definitely not a normal response. That would be 3 marks. But you ask the patient, sir, what is your mobile phone number? And in response to that, he's saying something that you could not understand. So you called your doctor colleague and you said, buddy, I need your help. I'm gonna ask this guy once again, what is your mobile phone number? Because he was brought by the cops, he's unaccompanied. He was found under a flyover, maybe he fell from a bike or whatever, he was beaten by some guys. So you asked the patient, what is your mobile phone number? And he said something that you could not understand and even your doctor colleague could not understand. That would mean incomprehensible words. Incomprehensible words, how do you remember it? That means mumbling by the patient, that he's saying something but it is not making any sense to you. On the other hand, obviously, one would be no response. You very well know that in Glasgow Coma Scale, there is absolutely no zero. So you can definitely work out the verbal response. Okay, the next thing, guys, we are gonna check for is the motor response of the patient, where I would like you to focus on the image that I have put on the extreme left hand side now. You can see the fact that if a patient is able to obey your commands. Now, how would you know that the patient is able to obey commands? You would ask the patient to make a fist or maybe move the big toe of your left foot, so the patient is able to do everything that I said. That would be 6 marks. But if he's not able to follow my commands, I'm gonna give him pain stimulus. And you can see the fact that wherever I have provided the pain stimulus, he is able to push my hand away. So because the patient is able to localize the pain, why I'm saying localization of pain is because of the fact that wherever I have provided the stimulus, the patient is able to push my hand away. That would be 5 marks for the patient. But if I'm providing pain stimulus to the patient, you can see if I'm providing pain stimulus, he is able to raise his arm but is not able to push my hand away. That is what is called as normal flexion. That was the point that was given in this MCQ, that the patient is exhibiting the flexion of this arm but he is not able to push my hand away. That would be 4 marks for the patient. On the other hand, you can see the fact that if I provide a pain stimulus to the patient and the patient is not flexing like this, rather he's moving his shoulder towards the midline. You can see in this case, what he's doing is when I'm giving him the pain stimulus, he is flexing his arm, right? But then he's moving inward, the arm is coming inward. This is what is called as abnormal flexion. Now that's the word I want you guys to understand. Difference between 4 mark and 3 mark, right? You provide pain stimulus to the patient, he just does like this. If he pushes your hand away, that is 5. If he just does like this, that would be 4. And if he's gonna be moving his arm inward, that is abnormal flexion, that would be 3 marks in a patient. On the other hand, you can see the fact that if a patient is having an extension response, the leg is obviously extended, but now in pain stimulus, the arm is also extended. That extension would be 2 marks for the patient. And obviously, if there's no movement, that would be 1 mark for the patient. So I've just tried to represent before you the motor response. Let us just revise the core thing once again and where the error can be. Error can be for flexion versus abnormal flexion. In this particular question that actually came in the exam, I checked with couple of students. It was simply written flexion on painful noxious stimulus to the arm. What I mean by this is what I have shown here before you, that is the arm of the patient is flexed but he's not able to localize where is the pain coming from. On the other hand, if he's just moving the arm across the midline, that would be 3 marks. An extension is gonna be obviously 2 marks for the patient. So most of the chaps, they can mess up in the motor response. So that is what needs to be remembered carefully. And would definitely like you to remember this particular slide so that GCS becomes a piece of cake for you. And do practice this by yourself in the various questions from whichever book that you're using or the app you are using. But then obviously GCS is something that is very important for the exam. Coming to the next question, it says postural tremors are seen in all except. First of all, you should know the meaning of the word postural tremors. So I'm just going to extend my arms in front of you. You can see gravity would be acting on my arm. It would be acting on my hands, but my hands are stable. I mean, I'm not having any tremors of my fingers at the moment. So the meaning of the word postural tremor would be primarily the fact that the patient should be able to keep his arm against a resistance, which could be something as simple as gravity, and the hand should be stable. If he is not able to do that, we call it a postural tremor. Now, people who are having alcohol withdrawal, they are having delirium tremens. And in delirium tremens, obviously, the patient is all shaky because there would be increase in sympathomimetic activity in the patient. So, due to this enhanced sympathomimetic discharge, you would be having this shakiness of the hands, dilated pupil, excessive anger, palpitation, sweating in a patient. So, yeah, we do get postural tremors in alcohol withdrawal. I mean, a person under intoxication of alcohol is obviously not able to maintain the position of the body, can fall down. But when there is alcohol withdrawal, there is a manifestation called as delirium tremens with increased sympathomimetic activity in the body that contributes to tremors. Essential tremors, well, some people, if you ask them to extend their hand like this, fingers like this, they would not be able to keep the hand stable, and they would be having tremors because some of us are, I would say, rather relatively nervous people and can have an enhanced sympathomimetic activity. So essential tremors are also because of increased sympathomimetic activity that will activate the beta 2 receptors in the muscles, and therefore you could be having postural tremors. That leaves you with two options to select: generalized paresis and physiological tremors. To solve the problem, you should know the generalized paresis of insanity, or GPI as it is known as. This is a psychiatric manifestation that is encountered with neurosyphilis. This manifestation is usually associated with development of agile Robertson people, and it is also associated with delusions of grandeur. Delusions of grandeur would mean that the patient will think that he is the God's gift to mankind, or he will think that he is the richest guy in the planet. I mean, he would obviously think very superior of himself and inferior of you. So, the bottom line is that generalized paresis of insanity is a neuropsychiatric manifestation that is usually seen with syphilis, and therefore is the answer to particular question. Physiological tremors, yeah, I mean, that's a very non-specific term, but yes, I would say like this, that physiological tremor is a term that is given in the literature for postural tremors. So we should give C as an answer to this question. How to remember this information? First of all, we will look at a quick mnemonic for paresis. That would be GPI, generalized paresis of insanity, which is a manifestation related to neurosyphilis. Normally, neurosyphilis, we have a gamma, right? And that results in damage to the brain. It results in agile Robertson people. So, personality changes, hyperactive reflexes, because there's a damage to the corticospinal pathway. ARP stands for agile Robertson people, that I basically spoke about. But the bottom line is that this manifestation is not related to postural tremors, first of all, and that is why it's the answer. I would also like you to look at these two handwritings that I mentioned before you. In one of the patients, that is superiorly, you can see that patient has written, "I cannot control handwriting." Especially when we look at patients of Parkinsonism. Patients of Parkinsonism, they write very slowly, and their handwriting is almost unintelligible. I mean, Parkinsonism patients, when they will write, you will notice the fact that every alphabet will become smaller than the previous alphabet, and you can see the fact that when a Parkinsonism patient will write, the alphabets are smaller than the previous one. So manifestation of Parkinsonism is micrographia, small handwriting. That's secondary to the tremors in the hands of the patient and the rigidity in the hand of the patient. The superior handwriting that I have shown you, this one, there is no reduction in the size of the alphabets. So this patient could be having presence of what is called as essential tremors. That would be that due to increased sympathomimetic discharge, he is relatively what we call casually as a person who is what non-medicals would cause a person who is a nervous individual. So essential tremors due to enhanced sympathomimetic activity can result in a poor handwriting in a patient. Beta blockers would be given, but in Parkinsonism, obviously specific treatment for Parkinsonism would be required. And inferiorly, whatever is given here, that is just unintelligible handwriting, which I have just put here to say that this could be scribbling by somebody who done it deliberately, or it could be even a patient of stroke who is not able to now even understand and comprehend the words per se. Like a patient of stroke, when you ask him to write, I'm saying like a person had a middle cerebral artery stroke, and he is having apraxia, so he'll not be able to understand alphabets. And therefore, if you ask him also and tell him that this is alphabet A or B, then he might be able to scribble some unintelligible words like this on the board. So handwriting can give us an insight regarding what is the neurological problem of the patient. And coming back to the question, it was simply the fact that postural tremors are found in all the following except the answer is generalized paroxysm insanity. You can once again revise the definition of postural tremor. It is that a tremor that occurs when the limb is held in sustained position against gravity, like outstretched arms in the patient, and there's a presence of a tremor that would normally be seen in patients who are having a alcohol withdrawal. Resting tremor is PD, Parkinson disease. Then is intentional tremors that are usually found in patients of cerebellar lesions. So there are following terms to be remembered: intentional tremor, cerebellar lesion; resting tremor, that would be Parkinson disease; essential tremor due to enhanced sympathomimetic activity is basically a postural tremor, in a sense that it would not be seen when the patient is keeping his hands like I am at the movement, but on outstretch of hands against a gravity you would be getting the tremor. So I hope the concept is clear here. Moving ahead, a 20-year-old military recruit is found to have a HbA1c of 6.1% with a fasting blood sugar of 120. Which of the following is correct about this patient? Guys, you are aware of the fact that glycosylated hemoglobin, the normal values should be less than 5.6%. If a person is having a HbA1c between 5.7 to 6.4%, that will definitely not be normal and would be included under what is called as impaired glucose tolerance. If the value of HbA1c goes more than 6.5%, it is obviously a diagnosis of diabetes mellitus. So this guy is definitely not normal, and the correct answer for this chap is impaired glucose tolerance. Diabetes mellitus is said to be present when HbA1c is more than 6.5, or for that matter of fact, fasting blood sugar is more than 126 milligram percent. You would then make the patient sit in your laboratory and make him drink approximately 75 grams of glucose, and you would tell the patient not to move around. Why not to move around? Because if you will move around, the muscles will consume the sugar, and therefore the borderline diabetic values might be missed. So person is sitting comfortably. After 2 hours, you will draw another sample, and if the 2 hour value is more than 200 milligram percent, it is a diagnosis of diabetes mellitus in a patient. So there are two ways of diagnosing diabetes mellitus, and in this particular question, neither of the two are being satisfied. So the answer is straightforward: impaired glucose tolerance, that is IGT. Maturity onset diabetes in young is also after all a diabetes. For that diagnosis, again, HbA1c should be more than 6.5%. This disease is usually seen in people at the peak age of 25 years of age. Like, for example, you have a 20, I mean, the diagnosis, please be very clear, it's not based on the age. I'm not saying that. What I am saying is that you need a HbA1c of more than 6.5% for diagnosis of MODY, which is one of the rarest type of diabetes. In fact, the peak age of onset of this disease is at 25 years of age, and the patients will mostly be asymptomatic. The only time the diagnosis of OD can be made is in an annual medical checkup. Like, this guy had applied for armed forces, and then his blood sugar was tested, and it was found that his fasting blood sugar was high. The doctor ordered HbA1c that was maybe 7%. So we need HbA1c for diagnosis of MODY, which are total of 6 varieties. That is MODY 1, 2, 3, 4, 5, 6. And the commonest variety of MODY that one should be aware of is MODY by 3. And out of all the varieties of diabetes, like type 1, type 2 diabetes, MODY, the rarest type of diabetes is MODY, and the commonest one is type 2 diabetes mellitus. Guys, my only suggestion for this question is that the values for diabetes mellitus are very straightforward. India is a hotspot for diabetes mellitus, no? So that is why they're always going to ask you about these aspects, which are very simple and straightforward. The next question is again from the topic of diabetes mellitus. The question said, what is the most common cause of fulminant diabetes? A lot of chaps after the paper, they said, sir, we studied fulminant hepatitis. And look at what he asked us, fulminant diabetes. Now, fulminant diabetes is primarily because of an insult by the virus. And that would be like, for example, it could be a virus like Coxsackie B. Traditionally speaking, Coxsackie B is responsible for development of myocarditis. But today we are talking about Coxsackie B and even mumps and even rubella virus. You see, these viruses, when they occur in children, they cause very little damage. But when they occur in adults, they cause substantial damage. So Coxsackie B, mumps, rubella, they are the ones which are the villains and can contribute to fulminant diabetes. Fulminant diabetes is an example of a type 1 diabetes mellitus, and it could be occurring in relatively, I would say, not children, but adults. The surprising thing is, if a healthy person like you and me will develop infection with these viruses, they could be a development of diabetes in 2 months flat. So you can understand the fact that insulinopenia and beta cell destruction would be a manifestation of fulminant diabetes. Let us just revise quickly. If they ask you what is the leading cause of type 1 diabetes mellitus, it would be answered by you as autoimmune destruction of the beta cells. That's the primary cause. But after autoimmunity, the second important cause for development of type 1 diabetes mellitus is what we have just studied in this MCQ. Fulminant diabetes is due to viral insult where a healthy adult can develop type 1 diabetes mellitus. A third important cause for this could be bronze diabetes. Let us recall what was bronze diabetes. This is going to be encountered in patients with hemochromatosis, that is iron toxicity, and we have a triad which we quickly need to remember for this particular topic. So in a patient of hemochromatosis, what's going to happen is that there would be iron toxicity, and this iron would be causing damage to the liver. So the manifestation in the patient would be development of cirrhosis. The iron is also going to damage the beta cells of pancreas, so it's going to cause a insulinopenia. And last but not the least, because this iron is going to get deposited in the skin, so there's going to be a bronzing of the skin of the patient. So if you combine all these manifestations together, we're going to call it a bronze diabetes. And these are the three causes for type 1 diabetes, out of which they had Oxford fulminant diabetes in your last exam. So it's a good idea to remember this. Moving ahead. What is the most common joint involved in diabetes? Now, instead of asking the traditional way, like earlier years, no, he was simply saying the word Charcot joints are found in. The answer is diabetes mellitus. And if you go through the previous year papers, I have mentioned Charcot joints are seen in diabetes mellitus. This time he just changed the English, right? He just said what is the most common joint involved in diabetes. So that would be the small joints of the foot of the individual that would be involved in this particular case. What do you mean by Charcot joints? Well, Charcot joints are painless paralyzed joints. These painless paralyzed joints that I have mentioned here before you, they could be a complication mainly because of the neuropathy aspect of diabetes mellitus. You see, we always tell diabetic patients not to walk around bare feet, not, or rather take special care of the sole of the foot, because diabetic patients always have a loss of sensation in the sole of the foot. That is one. So injuries to the sole of the foot can be neglected, and they also have a delayed wound repair. This delayed wound repair is secondary to the angiopathy component, that the blood vessels will also become relatively narrow. So the repair will process will also become slow. So look at the things that I said. There is a nerve damage, there is a blood vessel damage, there is a slow repair occurring, and all these things together could translate into development of, most of the time, a non-healing ulcer in the sole of the foot of a diabetic. I'll just show you the image on my next slide, but at the moment I want you to understand that diabetic patients can be having a non-healing ulcer in the sole of the foot, and that is definitely a neuropathic ulcer. Now, if there is some infection in this area, why? Because if you and me are having even a small injury in the sole of the foot, right, we will put up an antiseptic, we will avoid weight bearing on that area, we will do dressing of that area. I would like the injury to get healed as early as possible, because if there's an injury in my sole of my foot, I can't walk. In this person, he would neglect his injury. Why? Because of the fact that there is no pain. Pain is a feature that brings a patient to a doctor. You don't have pain, the patient is not going to come to you. So there would be a non-healing ulcer, it could get infected, and once it gets infected, the infection will destroy the joint spaces of the foot, and due to destruction of the joint spaces of the foot of the patient, there would be a development of Charcot joints. In the patients who are having a disease by the name of gout, if a single joint is inflamed, the person is literally having tears in his eyes, right? Like you study in gout, a patient would be having inflammation of the metatarsophalangeal joint. So patient would be with one joint involvement having tears in his eyes. And look at this individual. If I just zoom into this image, you can see the deformity in the joints. There is a local infection that occurred first, and then you can see the lytic lesions that are occurring in the bone, and apart from that, you can see the deformity in the foot that has come. So in this person, you can also see some amount of cellulitis in the dorsum of the foot. You can see how one foot is all swollen up. In fact, even the growth of the nails doesn't look very healthy in both of the feet of the patient. So diabetic patients, due to lack of foot care, could end up with a local infection deep inside. And yes, this is a horrible looking image. That's what I'm talking about. non-healing ulcer in a diabetic. I mean, on the heel of the foot, you would usually get it. So these are the manifestations that are usually going to be encountered in diabetic patients, and it is the small joints of the feet that are primarily involved in this particular disease. So coming back to the question, it simply said, what is the most common joint involved in diabetes mellitus? The answer would be the foot. The small joints, that is the tarsal joint, and the metatarsal joints are the tarso-metatarsal joints are the ones which are usually involved. When it comes to the involvement of the ankle, there is a neurological illness which is a manifestation of neurosyphilis, that is Taves dorsalis. So, since he has asked this, I would like you to remember that Taves dorsalis can cause involvement of the ankle joint. Knee joint is one of the weight bearing joints in the body that could be involved in multiple diseases, one of them being simply osteoarthritis. If a person is having too much of weight, obese people, they can develop premature osteoarthritis of the knees and might require a knee replacement. And well, shoulder joint involvement is seen neurologically. Shoulder joint involvement is seen with the disease called as syringomelia, as shoulder joint as syringomelia. And what do you mean by syringomelia? Dilatation of the central canal of the spinal cord. You see, the central canal would be having CSF. So dilatation of the central canal of the spinal cord can result in development of pressure on the adjoining tracts, and the pressure on the adjoining tracts would be then resulting in development of loss of pain and temperature sensation in the patient. And as I said, pain is a feature that brings a patient to a doctor. So if the pain sensation is lost, you see, then the person might neglect his injury, and that might result in a development of Charcot joints in the long run. Syringomelia, guys, is more common in the cervical part of the spine, and cervical fibers are gonna innervate the arms. So ultimately, syringomelia, because cervical spine is involved, the hand muscles can get involved. The hand could be having development of Charcot joints, whereas Charcot joints in the feet, soles, especially small joints of the foot, are gonna be seen with respect to diabetes mellitus. The answer to this question is delta D is the answer. Moving ahead in our discussion. Coming to the next question, he says, which type of insulin is used to manage a case of diabetic ketoacidosis? Now, this, guys, is a very common medical emergency which is frequently asked in an exam. And for management of this patient, you obviously need to give intravenous regular insulin. In fact, the basic point is that regular insulin is the only type of insulin that can be given both intravenously as well as subcutaneously. And in any emergency, I would definitely like a intravenous access. Diabetic ketoacidosis, initially the first line management is obviously to give normal saline to the patient. We need to give about approximately 5 liters, that is a huge 10 bottles of normal saline to be given over a 24-hour period. And well, what is the trigger for ketoacidosis? The trigger for ketoacidosis is insulinopenia. What happens in deficiency of insulin is that the fats in the body would be now the source of energy, because in you and me, insulin causes sugar to go into the muscles. So your and my muscles would be using sugar, but in insulinopenia, there is a fat oxidation, and this fat oxidation then results in production of ketones. And once the ketones are generated, they are the ones which are gonna then be used for energy production. So ketone production in type 1 diabetes mellitus especially would be skyrocketing. And once the ketones are gonna cause a drop in the pH of the blood, then acidosis will cause damage to the blood brain barrier. Water will go inside the brain and would then result in development of cerebral edema. In fact, this is itself a question. What is the cause of death in diabetic ketoacidosis? It is cerebral edema. And because I know I'm dealing with such a grave complication, I need a drug that can straight away raise the value of insulin. And what better than intravenous regular insulin, which would be a short acting insulin that would be administered to the patient. In this particular question, glargine can easily be ruled out because that is used for bedtime insulin. That would have left you with only 3 options to select, which would be Lispro aspart, are mainly given before breakfast, before lunch for regular management of diabetes mellitus and not in emergency scenarios. And because this is an important topic and they have asked about uses of IV insulin, so let us revise. When would you answer IV insulin in the exam? The 3 scenarios that have been asked and you should know is IV insulin is useful for management of acute hyperkalemia. Why? Because insulin causes potassium to go into the cells. If potassium goes into the cells, then the threat is stopped, because hyperkalemia can stop the heart. It can cause a diastolic arrest of the heart. The second reason why we give IV insulin is to combat the insulinopenia, that is diabetic ketoacidosis. And the third reason why we give IV insulin is to manage hyperosmolar coma. In this condition, usually the blood sugar is more than 600. If you have that high a sugar, the sugar will go in the brain, water will also go, so swelling in the brain again. That would result in fluid shift across the brain. I don't want that fluid shift to happen, so I need to downgrade the sugar. How would I do that? Intravenous insulin for the patient. Insulin is obviously the treatment of choice for type 1 diabetes mellitus. It is the treatment of choice also for type 2 diabetes mellitus, which is refractory to the usage of oral hypoglycemic drugs. So we do use insulin in type 1 and type 2 diabetes also, but that would be the subcutaneous insulin that we are talking about and not intravenous insulin, which would be recommended for the three situations that are mentioned here. And the answer to this question would be given as choice number A. Regular insulin is used to manage a case of diabetic ketoacidosis. Fairly straightforward. Moving ahead. This is a small table which I would like you to remember regarding the onset of action of the various types of insulin. Rapid acting insulin, the examples of rapid acting insulin are like Lispro and Aspart. Apart from Lispro and Aspart, we also use glulicine. So these injections usually start acting by 15 minutes. So before 15 minutes before breakfast, lunch and dinner, any of these molecules can be used. For emergency usage, we can be using short acting insulin, that is regular insulin. However, then we also have a long acting insulin analog, which is by the name of glargine, or in fact you should be also knowing ultra long acting insulin by the name of dagludec. In fact, dagludec is the longest acting insulin. It will act for approximately 48 hours, and the advantage of these insulins are that especially the long acting insulins, they are usually taken bedtime. There is no peak for these insulins. They are called as peakless insulins. What you mean by the word peakless is simply the fact that if you will give this injection of insulin, you will notice that it will act for relatively long duration, and that is what I want. A bedtime insulin should work till the next bedtime, that is for the next day. So these are the various varieties of insulin that we use. Do remember the name of the longest acting insulin also, dagludec. Will act for 24 hours, but dagludec would act for something in the range of 42 hours. So these inferiorly mentioned insulins are the long acting insulins that I want you to remember. And just remember the answer to this question also. Emergency cases, we are going to use always three scenarios where we are going to use IV insulin or acute hyper K, or diabetic ketoacidosis, and a hyperosmolar coma in the patient. My information that I have provided in the previous question will help you solve this particular question also. Slow onset of action and a lack of peak. Let's go back to the previous slide. Slow onset of action would mean that this injection will work after something like 1 hour approximately, but there is no peak of this injection. It lasts for 24 hours. So this solves this question also. Slow onset of action and a lack of peak is seen where the answer would be given with glargine. And if you look at Lispro, this would be a ultra short acting insulin. When it comes to regular insulin, that would be answered as rapid acting insulin. And then comes to NPH, that would be called as intermediate acting insulin. So getting pharmacology right is very important for this exam, guys, because that's a part of paper one. But I definitely want you to be rock solid in drugs. Not that it's just that you need to cram the name of the drugs, no, because few months from now you're gonna be doctors, you're gonna be writing prescriptions for people. So you need to be good with drugs, because if you know the side effects of drugs, you're more confident talking to your patients, because body language of yours is very important, especially interacting with Indian patients, because they go for vibes. Like in America, it's all insurance. They want is like cashless transaction, and they just want that, okay, doctor has seen me, fine, he will follow the protocol. In India, people are very concerned about your interpersonal communication, and that interpersonal communication is based on, right, your knowledge. Because if your knowledge is good, your way of talking would be more confident with the patient. So the rapport that you have with the patient is important. So don't treat it as only a intervention to try and clear an exam. That's not the goal, right? That's one of the small steps, baby steps. The main objective is get cracking as far as doing practice is concerned, because you're going to be all independent, couple of months from now, and you have to start writing treatment for your patient. Answer to this question: slow onset of action and lack of peak is glargine. Moving ahead, the question says, What is the most characteristic physical finding of prolactinoma after galactoria? Well, prolactinoma, if you have increased prolactin in the blood, that will stimulate the SNI of the breast and would cause a galactoria. So most of the guys, they were a bit confused in this question, because standardly he will ask you the manifestation of prolactinoma. Here he said after galactoria. So let's consider options. Bitemporal hemianopia. Well, there's a tumor in the pituitary. The tumor in the pituitary can press on the optic chiasma, and pressure on the optic chiasma can contribute to development of bitemporal hemianopia. So this definitely looks like a possible answer to this question. Let's read on. And ovulatory cycles, yes, because prolactin has an inhibitory effect on LH and FSH. So inhibitory effect on LH will contribute to bitemporal hemianopia, and the inhibitory effect of FSH, the follicles will not develop, so there would be a development of amenorrhea also. So choice A of the MCQ, choice B of the MCQ, in fact, that is anovulatory cycles, can be explained by inhibition of LH by the increased values of prolactin, and choice C of the MCQ can be explained by the inhibition of FSH by elevated prolactin, the amenorrhea component. And obviously, if LH FSH is not there, infertility would occur. So I'm still stuck. I mean, what is the characteristic physical finding? Well, the English words are to be remembered. Physical finding. These that I am showing here before you, anovulatory cycle, amenorrhea, infertility, this is not a physical finding. Please mark my words. Physical is what you can actually see. What can you see? Person is having a problem with his visual field. Like you can do test confrontation method and you can see that he is heavy blind. The question is regarding what is the physical finding. The physical finding is bitemporal hemianopia. The remaining, all of them are rather symptoms in a patient or manifestations of the disease, but they are not something that you can actually see. What you can actually see is that is a patient hemi-blind, because if you show him a target in the lateral part of the visual field, he would not be able to locate a target in the lateral part of the visual field, whereas he can see a target in the medial part of the visual field. So bitemporal hemianopia is a physical finding. You can check the visual field of patient by confrontation method. You can bring an object from lateral to medially. When you bring it from laterally, suppose I am able to see my finger at the moment in the lateral part. As I bring it medially, obviously I can see it. But in this particular patient of prolactinoma, if you showing your index finger and then bringing it medially, only when you bring it medially, patient is going to be able to see it. If the finger is laterally located in a bitemporal hemianopia, the patient may not able to see the object. So that's why this is a physical examination finding. And look at a huge prolactinoma. I mean, the optic chiasma is all crushed in this particular case, and this tumor would have resulted in extensive, or I would say irreversible, visual loss in this patient, and would require a surgery that would be called as a transsphenoidal surgery, where we hit this tumor through the sphenoid bone and remove this tumor. And therefore, going back to the original question, the question simply said, what is the physical finding of prolactinoma? That is bitemporal hemianopia. I would say the question was worded around English, right? This was a question where most guys got confused, so randomly people answered. But again, I said, you just need to keep your cool and look at what is he asking per se. So reading a question, analyzing like physical finding word, most common clinical symptom, what is the first step to be done, what is the drug of choice, what is the treatment of choice, there are different aspects. So you need to pick up the words in the question and answer it proportionately to the question. Like in this case, the answer for physical finding after galactoria is bitemporal hemianopia. For workup of this patient, I'll be doing a MRI head or a CT head, and I'll be able to locate the tumor with serum prolactin levels. The surgery of choice is obviously transsphenoidal surgery, but he can obviously test your pharmacology by asking you about a molecule by the name of bromocriptine, and then we also have a longer acting molecule by the name of cabergoline. Both of these molecules will raise the level of dopamine in the brain, and dopamine is inhibitory to prolactin. See, the sequence I have taught you is dopamine is inhibitory to prolactin, and prolactin is inhibitory to LH and FSH. If a patient is having elevated prolactin, LH-FSH would go down, so that will explain the symptoms of amenorrhea, a manifestation of infertility in the patient. And for treatment part, if I increase the dopamine, then this increased dopamine will counterbalance the increased prolactin and will reduce the manifestations of the patient. So like one hormone is increasing, I am increasing the a hormone that inhibits the release of this particular hormone, so I can control the manifestations in the patient. The answer to this question is A. Moving ahead in our discussion. Coming to the next question, it says ipsilateral third nerve palsy with crossed hemiplegia is a feature of. The moment you read the word third nerve palsy, it should click to you that the damage is in the midbrain of the patient. And at the same time, because third nerve originates from the midbrain, with crossed hemiplegia, that simply means contralateral hemiplegia. You will always notice the fact that in patients who are having a brainstem stroke, whichever side the cranial nerve will get involved, the hemiplegia will always be opposite of that only. That is normal neurology. No, corticospinal pathway always crosses over at the lower border of the medulla. So whenever corticospinal pathway is involved above the level of the medulla, it will always result in weakness of the opposite side. In fact, you know about this contralateral thing right from your biology days. You know, the right side of the brain controls left, left controls the right. So if any side the damage is there, the opposite side hemiplegia will obviously be seen. But the word crossed hemiplegia is just to explain to you the fact that the weakness will always occur opposite to the cranial nerve palsy, primarily because of anatomy, whichever side cranial nerve is involved. And hemiplegia is a manifestation that would occur opposite to that. Now, where would you get this combination is the selection from these names, and that is requiring a bit of ability to recall. The answer to this, guys, is called as Weber syndrome. In fact, that's a term that is used to describe midbrain stroke with third nerve palsy. Benedict syndrome is characterized by presence of third nerve palsy again, but this will also be having involvement or damage to the basal ganglia. How to remember? B. Benedict syndrome begins with alphabet B. Basal ganglia word also begins with alphabet B. So basal ganglia manifestations like chorea or ethiotosis would be written in the question. I repeat my statement again. Benedict syndrome is characterized by damage to the basal ganglia. So the patient will be having manifestations of contralateral chorea ethiotosis with a same-sided third nerve palsy. When it comes to Wallenberg syndrome, the blood vessel involved is vertebral artery or it could be posterior inferior cerebellar artery. Wallenberg syndrome does not have a hemiplegia but has the paralysis of the following nerves, that is 7, 8, 9, 10 and 12. These are the usual cranial nerves which are involved in Wallenberg syndrome. Horner syndrome can occur with respect to either lung cancer, or Horner syndrome can be seen with respect to even stroke, and Horner syndrome would be having a manifestation of ptosis. There would be a presence of a meiosis. There would be a enophthalmos. The mnemonic is perfect meal, that is perfect peace ptosis, then is meiosis enophthalmos, anhydrosis, that is lack of sweating on the affected side, and then would be loss of the ciliospinal reflex. Please remember the fact that when it comes to Horner syndrome in a patient, the damage occurs in the sympathetic chain. The sympathetic outflow is affected. So that is why these manifestations will occur. So you need to remember theory for solving this question. This question can be solved on not on simply cramming the data, but on the basis of remembering the aspects, and especially that the third nerve palsy, if written with contralateral hemiplegia, it's a midbrain stroke and is called as Weber syndrome. Okay, coming to the next question, guys. It says all are true, but the steps followed in the management of ventricular fibrillation except. Ventricular fibrillation would be having twitching activity, and there would be no PQRST waves that would be normally seen in the ECG. And the first thing that you would do in such a patient who's pulseless and babyless would be CPR cycle. The duration is 2 minutes. Yes, CPR is given in a ratio 30:2 and the duration is 2 minutes is a correct statement, and this is a except MCQ. Chest compressions are given at a rate of 100 to 120 per minute. A doctor is supposed to give approximately 2 chest compressions every 1 second. So 62s would be 120. So that would be a correct statement that the frequency of chest compressions should be between 100 to 120. Start CPR followed by immediate defibrillation. Now, yeah, first you need to give CPR and then you defibrillate the patient. And then he says intravenous access followed by immediate defibrillation. You see, at the moment I'm giving CPR, the next step would be defibrillation. IV line can be obtained even later in the patient. So the wrong statement in this question and the answer to this MCQ is choice number D, intravenous access followed by immediate defibrillation. The basic point that I want you guys to understand is that when you are having a ECG pattern like this, what would you do first? Because it will take some time for you to get the access to the defibrillator. CPR is the first thing to be provided, and then you will provide a DC shock to the patient at a intensity of 200 joules biphasic, and that should obviously bring the rhythm back to normal. If it not, you can definitely repeat the process after giving another CPR cycle of 2 minutes. And I've written into 3 because if you follow the protocol, there are a total of 3 DC shocks to be given. And if you are not able to revert back to normal, by that time almost so much time is lost that the patient is almost brain dead. So do remember, one cycle of CPR is 2 minutes. Into 3 times I have given CPR and 3 DC shocks I have given, and then the patient is not recovering, then there is no point of trying to continue the resuscitation further. This was an excerpt based question that is based on the routine, I would say, the basic life support program. So you have to attend it from the main lecture series, obviously, but then IV access is useful for cardiac arrest patients. Now, suppose this MCQ was regarding asystole, and the question was saying that in a patient with asystole, that is a flatline ECG in a patient, what would you do in the patient? Then you need to give IV adrenaline to the patient. This IV adrenaline will stimulate the SA node, it will restart the heart, and once you stimulate the heart, then obviously the cardiac activity would come back to normal. But there is no point of giving SA node in ventricular fibrillation because the heart is already beating in an abnormal fashion. In asystole, it's not beating at all. So IV line access is important for patients of asystole or cardiac arrest, but definitely not in patients of ventricular fibrillation. Answer to this question is delta. We move on to the next question. Comment on the diagnosis. Now, this was a question that was widely debated because a lot of guys, they just left the ECG based question. But one of the highlight features, I'm saying, however casual you are, if you look at this ECG, I think you can look at that the T wave in the patient is all inverted. So I am getting a T wave inversion in at least the following chest leads. If you look at it, I'm getting significant T wave inversion present in lead number V1. It is present right up to all the leads, right? All the chest leads are having a T wave inversion present. So this is definitely a feature that tells you that there is a ischemia in the heart. This T wave inversion is a feature very characteristic of myocardial ischemia, and there is no ST segment changes. This is the ST segment, the end of the S and the starting of the T. I'll just zoom it up for your convenience. I'll use a different marker. This is ST, and this ST does not show any change. There's no elevation, there's no depression, but yeah, you can see the T wave inversion occurring in the patient. So this is not a myocardial infarction, and therefore if you look at the options which are given here, comment on the diagnosis. Prince metal angina should be having a presence of a ST elevation, not visualized in this question. Pulmonary embolism, this would be having deep S waves in lead 1. It would be having a deep Q wave in lead 3, and it would be having inverted T waves in lead 3. The term that we use is called as S1Q3T3 pattern. S1Q3T3 pattern means deep S waves in lead 1. I cannot see any deep S waves in lead 1. Rather, it is a normal R wave which is predominant. S is not even seen. Then you cannot see any deep Q in lead number 3 of the patient. What you can see is a R and you can see is a S, but there is no Q because Q is before the R wave, so there's no deep Q. And there is no inverted T wave in lead 3. You can see that in lead 3 there is a positive T wave that is visualized. So I am ruling out S1Q3T3 as a pattern of pulmonary embolism for this particular question because obviously it's not present. And hyperkalemia will be having presence of what is called as tall tented T waves. So the choices were very well formulated by the examiner, and the correct answer to this question would be given as choice number B, that is myocardial ischemia, which is characterized by presence of T wave inversion in the patient, which is one of the very characteristic features of myocardial ischemia. Why not myocardial injury? Because I did get a query from a lot of students regarding that, doctor, why could it not be myocardial injury? I'm not very sure whether that was in the choices, but to be sure about injury, one, you should be having doubling of cardiac troponin I. You should be having a doubling of troponin I, or they should be elevated CPK-MB. That is, biomarkers should be positive. And second, in myocardial injury, you have a ST elevation, which is not present in this question. So therefore, the correct answer to this will be given as B, myocardial ischemia, due to a symmetrical. I'm saying symmetrical because all the leads are having this finding, asymmetrical T wave inversion present in all the leads is why I have given B as an answer to this question. You can just look at the heart rate of this guy here, how to calculate the heart rate. you have to look at the number of the squares between the R and the R waves. And in this particular question, I can count something in the range of about 4.5 to 5 large squares between the R and the R waves. So formula for heart rate is 30 divided by the number of the large squares between the R and the R waves. And here you can see there are 5 large squares. So if you divide 300 by 5, that would be a heart rate of approximately 60 per minute. So one thing is sure, that this question is not definitely on tachyarrhythmia or a bradyarrhythmia, because the heart rate is within the physiological range. And then there is no characteristic ST elevation also, so myocardial infarction can also be ruled out. So all you're noticing is that very pronounced T waves, which I highlighted even in the previous slide before you, in almost all the chest leads of the patient. So that tells you there's a myocardial ischemia. There could be some blockages in the artery which could be contributing to it, and that is why the answer was given as myocardial ischemia in this question. Well, coming to the next question, he says, which of the following is used for the management of the 65-year-old patient with respiratory distress? Bedside echo shows a ejection fraction of 35%. Well, one, you can definitely see the fact that in this patient there is a very characteristic bat wing pulmonary edema present. You can see the whiteness which is present in both the lung fields of the patient. So that definitely indicates presence of bat wing pulmonary edema. On the account of this bat wing pulmonary edema present in the patient and a low ejection fraction, so I am taking for keeping the diagnosis as congestive heart failure for the patient. And for management of congestive heart failure, we need to give the following protocol: LMNOP, that is, L is Lasix, which is present in all the four options; morphine, because it reduces pulmonary edema; nitroglycerin, because it reduces both preload and the afterload; then is obviously oxygen and positioning in the patient. On the basis of this background knowledge that you should have in your mind, option A is Lasix nitrates and then sacubitril valsartan. So in patients who are having acute heart failure, there is no role of giving sacubitril at the moment. So yeah, in chronic heart failure, I will use this patient, but he has here mentioned that a man has presented with distress. He's having a low ejection fraction, so he's an acute heart failure. So that's why I'm ruling out choice number A from the possibility. Norepinephrine is anyway ruled out because that is used in management of septic shock. In this case is not of a septic shock. Choice number C says Lasix nitrates morphine. That looks okay and decent to me. The last one says ACE inhibitor. Okay, we can use that if he was hypertensive, but then digoxin is not used in acute heart failure. You see, in pharmacology they talk a lot about digoxin, but digoxin is not used in management of acute congestive heart failure in a patient. Why? Because it increases myocardial oxygen demand. Plus, digoxin is a pro-arrhythmogenic drug, because it has tendency to cause development of arrhythmias. So it would not really make sense for you to actually use digoxin in acute congestive heart failure, and therefore the correct answer to this would be choice number C. I'll give Lasix because it will reduce the preload, nitrates which are going to reduce the preload and the afterload, and morphine because morphine is not a painkiller, guys. I agree, I mean, it's a painkiller. Here there's no chest pain now, so here I'm not giving it for management of chest pain. Why am I giving morphine to this patient? Because morphine causes shunting of blood from the pulmonary to the systemic circuit. What that means in simple English is that it will cause blood to go from the pulmonary circuit to the systemic, so it will reduce the pulmonary edema component. So my objective is to reduce acute pulmonary edema in the patient, and these are the drugs which would help me with this. And therefore the question was based on your knowledge of ability to identify acute heart failure in a patient. Step 1. Step 2, do you know the management acute heart failure? Very straightforward, LMNOP. And this has to stay with you guys for whole of your life, guys. I mean, you start working in any hospital, heart failure cases will anyway come, post myocardial infarction, or it could be cardiomyopathy patients, it could be patients who are having myocarditis. So yeah, you need to know this basic management protocol, and the answer to this is very straightforward. That is choice number C to this question. Which of the following leads to a continuous murmur? First, we need to understand definition of the word continuous murmur. You see, this is heard both in the phase of systole and diastole. Period between S1 and S2 is called as systole. Period between S2 and S1 is called as diastole. The murmur will occur, the turbulence in the heart will occur in the both phases of the cardiac cycle. One of the main diagnostic features of continuous murmur is it is heard in systole and diastole, and the second diagnostic feature of continuous murmur is that it always peaks at S2. Now let's take up the first option, peripheral pulmonic stenosis. It basically means in simple English that there is a pulmonary artery narrowing And you see, guys, blood flows through pulmonary artery, whether it is systole or diastole. I mean, blood has to flow through into the lungs, both in systole and diastole. How would the blood flow in systole? The power of the heart. And how would the blood flow in diastole? The elastic recoil of the vessels, the peripheral resistance. So I repeat my statement. The power of the heart in the systole is the driving force for blood in forward direction in the pulmonary artery. In systole, diastole is elastic recoil of the vessels that would ensure a forward flow of blood. And if your pulmonary artery is narrowed, you will have turbulence. That turbulence will be present both in systole and in diastole, the elastic recoil. So this looks like an answer, but let's look at the next option, severe pulmonary artery hypertension. In severe pulmonary artery hypertension, the high pressure in the pulmonary artery causes leakage of blood back into the chamber of the heart. It causes leakage back into the RV. This leakage back into the RV will occur in the phase of diastole. You see, blood goes out of the heart in the phase of systole, and here the blood is going back into the heart in the phase of diastole. So that leakage will produce a diastolic murmur. So choice number B, how am I ruling it out, is simply the fact that severe PAH leads to blood to leak back into the heart in diastole, causes a diastolic murmur. So it has been ruled out. Type A aortic dissection does not have a murmur most of the time. It will just cause the patient to become hemodynamically unstable, and in fact the presentation of aortic dissection can be BP can be unequal between the two arms, but you don't hear a murmur. So therefore I'm ruling this out. Rupture of cardiac chamber will again result in patient dying. You see, let me say, a patient had a full thickness MI. If a patient had the transmural, that is a full thickness myocardial infarction, the heart will simply rupture like a balloon, right? And when the heart is going to rupture, then the BP will become unrecordable in the patient. So I have ruled out choice number C and D in this question, because those are situations where you won't have a murmur, but the patient is becoming pulseless and BP less, and most of the time you would unfortunately lose the patient. The correct answer to this question is choice number A. Peripheral pulmonic stenosis results in a continuous murmur. Why you need to know this is because traditionally speaking, we all know that continuous murmur is seen in PDA, patent ductus arteriosus. We all know that it is also found in coarctation of aorta. Why? Because there is presence of collaterals. There is presence of collaterals in the heart, and those collaterals would result in development of a continuous murmur. The third input I want you to remember is what was the answer to this question, that is peripheral pulmonic stenosis. That simply means that there is a narrowing of the pulmonary artery, and the narrowing of the artery would then result in a continuous turbulence to be occurring both in the phase of systole and diastole, and would result in the manifestations there. So answer to this question is choice number A, peripheral pulmonic stenosis. Moving ahead, what is true about postural hypotension? Like you are aware of the definition of hypertension, you need to be aware of postural hypotension. So postural hypotension is defined as a fall of blood pressure. In all the options, there's a decrease in systolic, decrease in diastolic blood pressure. So let's just get the definitions right. You would first take the patient's blood pressure in supine position, then you would tell the patient, sir, please stand. When he will stand, you will not immediately take the BP, but you would be waiting for 3 minutes before recording the blood pressure of the patient again. If the change of position of the patient causes blood pressure systolic to fall more than 20, and the diastolic blood pressure of the patient to fall more than 10, then it indicates the fact that the patient is having a presence of postural hypotension. So the correct answer to this question would definitely be a decrease in systolic blood pressure. You see there are two options with 3 minutes time lag, and he says decrease of systolic 20 millimeter, and look at the words now, diastolic blood pressure 20. So choices are crafted very cleverly, guys. If you are gonna go in the exam without preparing MCQs, that is like you don't know how the battle looks like. You are going to into a battle with the opposition having gunfire, and you are going with a knife to fight them. So doing MCQs is important, no? Like you would have people who would say, okay, do only notes. You see, doing notes is like you say, okay, I have learned partly and I'll go and apply it in the exam. Application will obviously require a lot of effort on your part. The correct answer to this question would be given as choice number beta, that is decrease in the systolic blood pressure within 3 minutes of a postural change. So the wordings of the questions obviously have to be practiced. The question says a berry aneurysm most commonly occurs due to. And he has not asked today about the site, but is rather involving which layer of the blood vessel is mainly involved in this patient. So the bottom line is like this, guys, that we have tunica intima, we have media, we have adventitia, we all know that. And then we have what is called as the internal elastic lamina, which would be in a circumferential fashion around the blood vessel. And the defect of this results in a weakening in the wall of the blood vessel that causes the saccular aneurysm, which is called as a berry aneurysm. The answer to this question would be given as choice number beta. Why answer is not A? Because it says endothelial injury to the vessel. So this is not a disease of tunica intima. This is a disease of mainly the internal elastic lamina and the tunica media. A and C, they almost look the same, right? The concept behind them is same, tunica intima involvement, so I'm ruling them out. And that means the fact that I'm left between B and D. Adventitia is the peripheral part of the blood vessel, right? And that's not involved in this condition. The main structural defect in this condition is intimal elastic lamina, and along with that is also the involvement of the tunica media. So answer to this question is given as B. We move to the next one. A 45-year-old worker, a factory worker for past 20 years, is having breathlessness. The CT scan shows pleural thickening and fibrosis. Now, one, you are having a occupational history present in a question. There is a definitive, history suggestive of pneumoconiosis. And then the key word is pleural thickening. So that is pointing towards a presence of a lesion by the name of mesothelioma, because mesothelioma is seen in patients of asbestosis, and they are the ones who develop this pleural plaque formation. In fact, this question has deliberately been created to trouble you, because if he was simply asking you this question like pleural plaque formation is associated with, your answer would have been a mesothelioma, spot on. But he just tried to waste your time by writing regarding a factory worker, then developing breathlessness, then the CT scan findings. So they're trying to give a clinical edge to the question, and the answer to this question would be given as A, that is asbestosis, obviously, because mesothelioma is a direct result of asbestosis. It's in fact a cancer that can cause damage to the lungs of the patient. Coal workers' pneumoconiosis is unlikely to be an answer to this question, because you do not have a pleural plaque calcification. Rather, this condition, coal workers' pneumoconiosis, causes a progressive massive fibrosis. Silicosis usually results in bilateral hilar lymphadenopathy with the eggshell calcification. And apart from this, in patients with silicosis, you could also be having a miliary pattern. So none of the patterns that I have mentioned here are given in the question, so is ruled out. And berylliosis, beryllium is rather relatively a rare diagnosis, and I would suggest you not to go for rare, but rather to go for the common ones. The answer to this question is A. The most commonly observed autosomal aneuploidy leading to spontaneous abortions. You see, I would like to tell you guys that trisomy 16 is a condition which is never seen postnatally. Now, God has or I would say nature has a way of getting rid of defective babies. So trisomy 16 has a 100% abortion rate. That is why you will never see trisomy 16 to be present in a case per se. I mean, it is diagnosed on ultrasound, or it could be diagnosed on basis of the karyotyping of the fetal material, but is never seen postnatally, secondary to 100% abortion rate. So God has created his own mechanisms of destroying defective babies, and that is why the question said autosomal aneuploidy leading to spontaneous abortions. Is the answer is A. Down syndrome, monosomies, or trisomy 18s, I mean, we do see clinical cases. So this is, I would say, a fact-based question. In this one, ruling out options is not the way to go forward. It's just a fact that has to be remembered. One, you all know, you see, even your gynecologist would tell you that spontaneous abortions are due to defective chromosomes, and second trimester abortions are due to cervical incompetence. You all know that. Now here they went a little deeper and they said, okay, chromosomal abnormalities, which one? And that would be a 16 trisomy. That is, A is the answer to this question. Which of the following is a nephritic syndrome? If you look at alpha choice minimal chain disease, this is definitely a cause of nephrotic syndrome, and in fact is one of the leading causes of nephrotic syndrome with respect to children. Membranous glomerulopathy also causes nephrotic, but is seen after 65 years of age. Post-infectious glomerulonephritis is the alternative name for post-streptococcal glomerulonephritis. This is going to result in development of hematuria with hypertension. This is the standard manifestation that you see PSG and post streptococcal glomerulonephritis, and then focal segmental glomerulosclerosis FSGS. Right, this is the leading cause of nephrotic syndrome with respect to adults. So when it comes to this particular question, I just want you to remember the fact that you should be knowing the etiologies of nephrotic syndrome for children, adults, and geriatric population. And C is the one that has a nephritic syndrome. In nephritic, you have a I. I would mean there's inflammation of the glomerulus. Inflammation of glomerulus will cause RBCs to leak, and therefore you have is hematuria. Do you have RBC in urine of a normal person? Yes, less than 3 RBCs per high power field. If you're more than 3, that is obviously abnormal. In this case, there would be gross hematuria, and because there is a vasculitis, there is damage to the blood vessels of the kidney, so the glomerular filtration rate would be less. That will stimulate the RAS system, and the stimulation of RAS system would result in high blood pressure to develop in the patient. So which of these is a nephritic syndrome? The answer is C, post-infectious glomerulonephritis. He again played with English language here. It started writing PSG and nephritic. He just wrote it post-infectious, and that causes a doubt in your mind. Am I reading right? Yes, you're reading right. Post-infectious is same as post-streptococcal. The answer to this question is choice number C. The following serological status is noted in a patient. The patient is surface antigen positive, IgM class of antibody to core antigen positive. These two things together, guys, is acute hepatitis B. And E positivity. Carriers are surface antigen positive people for a duration more than 6 months. Normally we are able to clear this infection from our body. It's a very harmless infection. It is media that makes it sound very dangerous. No, that hepatitis B is a very dangerous infection. No, man, it's a very straightforward viral infection. The body is able to clear it off within a matter of couple of weeks, and therefore 90% cure rates are seen spontaneously. If somebody fails to clear this infection, carriers are not going to have disease themselves. They're going to transmit it to family members. So carrier definition is positivity for more than 6 months. This chap is having acute hepatitis B, so I'm ruling out chronic anyway, because when do you say person is having chronic? He should be surface antigen positive, plus he should also be having this antibody by the name of immunoglobulin G class of antibody to the core antigen. So when you have combination of the two, surface antigen positive as well as immunoglobulin G class of antibody to core antigen, then the combination of the two is chronic hepatitis B, and this patient is having IgM, so is acute viral hepatitis with infectivity. Choice D says remote infection. Remote infection patient would be having most of the time a presence of a residual. These people would be surface antigen negative, obviously, because they have cleared the infection, but this antibody can still be present in the body of this patient, that is IgG class of antibody to the core antigen. So that simply tells you the fact that he had an infection, he was able to clear the infection from his body, and therefore the word used is remote infection. Remote here means that it occurred in previous couple of months or years. Therefore the answer to this question is A, acute viral hepatitis with infectivity because the antigen is positive. Chronic viral hepatitis is seen with. Now, the leading cause of chronic viral hepatitis in the world is hepatitis C. That's a straightforward fact-based question. Hepatitis C is the leading cause of development of cirrhosis. It is the leading cause of development of end-stage liver disease. Both the C's, that is cirrhosis and chronic viral hepatitis, is hepatitis C. And the drug of choice for this condition would be answered as lepsidavir. That's additional information that you can remember. We treated genotype wise, and the remaining viruses, yeah, they can be causing chronic hepatitis, no doubt about it. Not hepatitis E, obviously, that would cause acute, but then the leading cause of chronic viral hepatitis is the crux of this question. Therefore the answer is C. Acute autograft rejection occurs within few hours is what is for hyperacute rejection of the kidney. I mean, even before the surgeon would close the abdomen, a hyperacute rejection will occur, that is within minutes only or within hours only, because of the fact that this was, let me say, an unrelated donor in the patient. So even before the abdomen is closed or after closure of the abdomen, immediately I can say that the kidney can become cyanosed and mottled. That would be a hyperacute rejection of the kidney. The technical definition for acute rejection is in the first 6 months, and if it is after 6 months, then we call it chronic rejection. So the answer to this question should be given as choice number C. Some people answered within 1 month only. I don't know why, but the technical textbook definition is within a six month time frame, and we are mentally prepared for it. No, if acute rejection will occur, we will give anti-rejection drugs to the patient that will prevent such manifestations from occurring. Like we can give mycophenolate, or we can be using drugs like sirolimus, which is a non-nephrotoxic anti-rejection drug. We anyway give mycophenolate and prednisolone, and we can upgrade the game by giving sirolimus to the patient also, so that rejection episodes can be prevented. So rejection will always occur whenever a person is partially matched. Obviously complete match is only possible if two babies are developing from the same fertilizer, that is monozygotic twins. In those circumstances, if two babies are going to develop from the same fertilized egg, in those circumstances, that is the monozygotic twins, in those circumstances, you are unlikely to have a rejection because both the babies would be having similar genetic material. So that kind of a transplant is called as syngeneic transplantation, or is called as an isograft. But when it comes to a family member donating organ to the person who's obviously in dire need, then it would be a partial match, and that would be resulting in acute or a chronic rejection within 6 months and after 6 months respectively. And the transplantation that occurs from a first degree relative is the one that is called as allogenic transplantation. And xenograft is a term that is used for graft that is coming across species. So answer to this question is C. Okay, coming to the next question, he says type 2 hypersensitivity is seen in. Well, guys, type 2 is an autoimmune reaction. So autoimmunity would be choice number A of this question, that is pernicious anemia. You know that pernicious anemia would be vitamin B12 deficiency due to deficiency of the intrinsic factor. Intrinsic factor is produced by the parietal cells, and parietal cells are destroyed in a condition that is called as autoimmune gastritis, which is also called as type A gastritis. Let us look at choice number B here, that says serum sickness. That's an example of type 3 hypersensitivity reaction, and so is the case for Arthur's phenomenon as well. So you can easily rule out choice number B and C in this question. Pathergy phenomenon is useful for diagnosis of Behçet's disease, also called as Silk Road disease, and this is an example of type 4 hypersensitivity reaction. I would suggest you to read the table from either solutions book or from your coaching notes, whatever you find comfortable. But every year there's a question, every session there's a question on the types of hypersensitivity reaction. So I would definitely like you to read about it. And the correct answer to this question is A, that is pernicious anemia. The question says, which of the following is a causative agent of farmer's lung? Well, the correct answer to this, guys, is option A itself, that is thermophilic actinomycetes. When I spoke to a lot of students, they got confused between actinomycetes and aspergillus. Well, Aspergillus fumigatus is responsible for a condition called as allergic bronchopulmonary aspergilloma, and this would be presence of black sputum plugs in an asthmatic patient. Now that's gonna look very gross, no? Black sputum plugs in an asthmatic patient. So there is no reason to be confused if you read well for this particular question. If you look at C. acinetobacter or actinobacter, these are organisms which are usually seen post blood transfusion. They could be like growing on the blood bag, and if you are giving blood transfusion for a long duration, then infection could be occurring with this bacteria acinetobacter, or it could be contributing to ventilator associated pneumonia. So CM ruling out anyway, because that's mainly related to VAP, ventilator associated pneumonia, or sepsis after blood transfusion. Aspergillus flavus has been asked earlier, that is causing hepatocellular carcinoma. So there are three learnings in this question. First is obviously the name, farmer's lung, which is an example of hypersensitivity pneumonitis. It's a occupational lung disease with respect to organic dusts. So hypersensitivity pneumonitis, HP as they call it, is mainly responsible for causing damage to lungs in farmers' occupational exposure, organic dust going in, and the fungus that grows is one that is by the name of thermophilic actinomycetes. And I also want to tell you that it is the same fungus which also grows on sugarcane dust and results in development of bagasosis and thermophilic actinomycetes. The correct answer to this question is choice number A. Okay, coming to the next one, he says comment on the diagnosis. They gave a peripheral smear. In the peripheral smear, one, you can notice this very characteristic, what I'm going to call as a banana shaped gametocyte, And most of the guys, because they are well versed with the theory part here, the banana shaped gametocyte of falciparum malaria, so they could crack the question and answer it as choice number A. In fact, I can just zoom in and show you the fact that in the RBC you can also see the multiple ring stage. Vivex will be having a single ring stage, but here you can see multiple ring stage that is seen, which is obviously diagnostic of falciparum malaria. The appearance is also called as headphone appearance, and the combination will make you give a diagnosis as A. Why answer is not B is because in hereditary spherocytosis, spherocytes would be seen. And how would spherocytes look like? Normally, red blood cells are supposed to have a central pallor. The inside of the RBC is gonna be white, but there would be some RBCs, if present for spherocytosis, that would lack central pallor. So I've drawn spherocytes before you. Spherocytes are red blood cells which are relatively smaller in size, and they lack the central pallor, which is normally present with red blood cells. So that is why I ruled out. G6PD deficiency will be having RBCs which have this appearance of what is called as bite cells, like somebody's taken a bite into an apple. And thalassemia will be having RBCs that would be having a target appearance. So target RBCs are not visualized in this case. I'll just sketch it just for the heck of it so that you can remember it. Target red blood cells for thalassemia, bite cells for G6PD deficiency. Spherocytes I've shown, they look smaller, they lack central pallor. So you can easily rule them out, and therefore the answer is A, malaria, for this question. Moving ahead. One of the easiest questions of this exam, right? Whipple disease is caused by, that would be bacteria. This would be a bacteria by the name of Trophaerma whippleyi. A bit of tongue twisting name. Well, what does this bacteria do? It causes malabsorption syndrome. This organism can be stained by a reagent that is called as Schiff's reagent, or is also called as pus. The advantage of this Schiff's reagent is, or the pus reagent is, that this Schiff's reagent would be helping you identifying this intracellular bacteria. Remember the fact that Helicobacter pylori is a extracellular bacteria, but this would be a intracellular bacteria that would be found in the macrophages of the intestine. So to identify this organism, we will have to use a stain. It could be a routine stain, it could be silver stains also. And once we identify, we will have to give IV ceftriaxone to eradicate this deep-seated infection. Don't be surprised if I'm using ceftriaxone for management of malabsorption syndrome, because this is a deep-seated infection in the gut. And once the patient is better, I will switch the patient to oral cotrimoxazole, which would be given then for a duration of approximately 6 months for the patient. So the data to be remembered is Whipple's disease is caused by intracellular bacteria. This is obviously not to be confused with the related MCQ Whipple's triad, which is for insulinoma. And this is also not to be confused with the topic which is by the name of what we say as Whipple's operation, which is done for obviously cancer of the head of the pancreas. So I thought I'll just mention the related terms also that you guys should be familiar with. Moving ahead. What is the most common site of brain metastasis? I mean, where would the brain metastasis come from? That would be straightforward lung cancer. It is Oat cell cancer that can easily metastasize to the brain. Apart from lung cancer, the second most common cancer that metastasizes to the brain is the breast cancer, and then can be malignant melanoma. So breast cancer is in options, but that is occupying the second point. So answer is lung cancer to this question. Which is not seen in tumor lysis syndrome? Well, to understand this question, let us take this to be a cancer cell. All cancer cells will be having a big nucleus, a big nucleus. And inside this nucleus would obviously be present DNA. The DNA would be breaking down to obviously produce uric acid. Inside every cancer cell, there would obviously be ATP for energy and potassium. So when I'm gonna kill this cancer cell with chemotherapy, it's gonna release this potassium in the blood, and therefore all patients, when they are having these millions and megatrillions of cancer cells being killed by chemotherapeutic drugs, then when so many cells will die simultaneously, the potassium will come in the blood and will cause a hyperkalemia. The ATP will break down, And this ATP will generate adenosine triphosphate. The phosphate in the blood would be elevated, and this will chelate with calcium. Once it chelates with calcium, the values of ionized calcium and total calcium will reduce because it is consumed in the chelation process. And because in this condition the DNA will break down, the breakdown of DNA will result in production of uric acid. And the bad news is that these uric acid crystals will block the tubules of the kidney, and blockage of the tubules of the kidney would result in development of a urate nephropathy, which will result in shutting down of the kidney for good. The basic point I want you to remember is that when it comes to chemotherapeutic drugs being used, urate nephropathy as a manifestation in the patient would result in development of a renal shutdown. It would result in ATN, acute tubular necrosis in the patient. Now the question says, which of the following is not seen in tumor lysis syndrome? Hypophosphatemia. We have a hyper. Why? Because the ATP is breaking down. So this looks like an answer. Hypocalcemia, yes, is seen. Hyperuricemia, because of the DNA breakdown. I told you the nucleus will break down to produce uric acid. Hyper K, why? Because all cells are rich in potassium. When you have millions of cells dying simultaneously, the potassium values will spike. The correct answer to this is hypophosphatemia, which is the wrong statement here, because what we see is hyper because of the ATP being the source of generation of phosphate. Coming to the next question. He says, comment on the diagnosis for SAP being normal, PTH being normal, vitamin D3 is normal. Everything is normal with elevated calcium. Vitamin D intoxication is ruled out because vitamin D levels are given to be normal. That is why I have ruled out vitamin choice number A. Hyperparathyroidism will always have elevated serum alkaline phosphatase and elevated PTH, and in this question, PTH is normal. That leaves you with multiple myeloma and rickets. Now, nutritional rickets is a condition with deficiency of vitamin D3. It has low calcium, it has low phosphate, and it has increased serum alkaline phosphatase due to increased bone turnover. So you can solve this question simply by this word: SAP is normal. SAP normal is a characteristic feature of osteoporosis, which I thought first, I thought it could be question of osteoporosis, not in the options. Multiple myeloma. So two important conditions where SAP is normal, and you must know serum alkaline phosphatase that is produced from bones and indicates bone turnover is normal in osteoporosis. That is why we don't do serum alkaline phosphatase and calcium phosphate in osteoporosis. No, we straight away do DEXA scan for the patient. And serum alkaline phosphatase is also normal in patients of multiple myeloma. So these are the details that I would definitely like you to remember for multiple choice questions. That SAP values are normal in osteoporosis, multiple myeloma. Answer to this question is choice number C. Which of the following interfere with iron absorption? Well, we Indians are anemic as compared to Americans. Why? Because the food that we eat is mainly cereal based. And the cereals that we guys eat, they contain competitive inhibitors of iron absorption. The main competitive inhibitor of iron absorption that I want you to remember is phytate. Along with this, tannic acid is another competitive inhibitor, and that is why I would say the hemoglobin of Indian population would be relatively lower as compared to that of American population, because the food products that we eat, they rather reduce the availability of iron. The bioavailability of iron is anyway 10%. Like if you eat 30 milligram in a day, you would only have 3 milligram coming in your blood, and with Indian diet it is even lesser. So that's why the anemia component is lesser. Most of the questions are very straightforward, guys, as you are seeing, right? The next one says sensitive and specific marker for MI. The best answer for this would be troponin. Troponin I and troponin T is the most accurate way for identification of myocardial infarction. If the question simply says, what is the first investigation to be done in a suspected case of myocardial infarction, obviously it is ECG. But if the question says, what is the best test? If the question says, what is the most specific test? If it says investigational choice, then it is elevated cardiac biomarker, because if there is necrosis in the heart, then the biomarker, that is troponin I, troponin T, CPK-MB, they would always get elevated. The necrosis would cause them values to become elevated, and doubling of troponin I, 2 times elevation of troponin I, is the usual presentation that we see. Cytokeratin is related to cancer, so that is why I have ruled it out. Myoglobin can be coming from skeletal muscle, as well as from the cardiac muscle. The problem with myoglobin is, like, suppose you gave a DC shock to the patient. So DC shock will cause damage to even the skeletal muscles of the chest and can result in elevated CKMB, and it can also contribute to elevation of myoglobin due to damage to the muscles. So because myoglobin is present in skeletal muscle, cardiac muscle, so myoglobin, you really can't be very sure what is the source. And CPK-MM, well, that is present in only the skeletal muscle. In the heart we don't have CPK-MM. In heart we have CPK-MB. So couple of guys got this wrong. They casually read CPK-MM. They did not, they thought it is MB written. They just wrote C, saw CPK and answered it. The answer to this is troponin, and he did not write INT, maybe because he wanted to create some disparity. So again, this is, I would say, silly question that can definitely go wrong. So please be very particular when you are attempting questions, because the wordings of the questions are the ones that matter. I've deliberately kept the difficult ones in the initial part, the easier ones subsequently, and you will notice this pattern in the exam, guys, that you see every cloud is a silver lining. They're gonna mix and match the data. They're gonna give the difficult ones, they're gonna get the easier ones. So don't get bogged down by the difficult ones. Most people are just wondering about those 50, 60 difficult questions. Those are going to be terms that will make you feel miserable. They deliberately want you to feel as if you know nothing, because go back to your medical college, when you see those consultants back there, right, all they want is to make you feel miserable. What I want you to understand is those 60 things are like difficult cases in your practice, but the easier cases you can anyway handle. You are skilled, you have put 5.5 years of your life into medical school, so you can easily solve the routine cases that come in your OPD, in your wards, and that is what they want. Can you handle the routine cases? They don't want you to be a super specialist, they don't want you to do rare data. So my only request to you is do notes and questions together. It's a combination, guys. You're doing only questions, doesn't make sense. You do only notes, that doesn't make sense. It's a balance, right? It's going to war. You need to know what your enemy is up to, because then you can strategize, and you can put more effort in those topics or subjects which are important. And integral medicine is a combination of all of them. So I want you to put in your heart and soul into this, guys, and I wish you the very best for your preparation. I'm very sure that I'm gonna be taking interviews, a couple of you, very soon in the next couple of weeks. Thank you so much, guys. Keep saving lives, and everything that you do, you are special. You have to realize you are the cream of the society, right? Nobody, people dream to be a doctor. You are already there. It's just that you have to go and touch the finish line. So my best wishes to you. Thank you so much.